Hang on a second. There we go.
So this is supposed to be an interactive lecture on early viral treatment post-pandemic clinical applications, a roundtable discussion. So my name is Stefan Hartman. I'm a PA. I'd like to be the moderator for this. And I'd like to draw from the crowd, if we can get some volunteers. What we're going to do is basically we're going to go through each therapeutic, describe best use, dosing, your clinical experience on these, side effects you may have found, other findings in the advent of using these things. You learn about other applications for these, talk about availability and mechanism. I don't know if Dr. Joseph is here and Halasa, they're the guys who love to describe mechanisms. But yeah, I don't want to just speak and talk to myself the whole time. Do we have some expert volunteers that we can add to the list that I could draw from? Bill?
Well, I don't know if I'm an expert, but I'm available. So,
Well, we're going to be asking you all in turn. We'll put Bill Clearfield on the list here.
So I think Dr. Halas is in Libya from what I heard. So he wasn't on his last night, I don't think. So
can we get Dr. Kalpana Patel?
We know you're hiding there, Dr. Patel.
I know she's listening in. Can we get Dr. Benoit Tano? You're muted, Dr. Tano.
Got it. Yes.
Dr. Tano, I'm looking for speakers tonight. We are doing a roundtable discussion on viral treatment applications. And so what I'm going to be doing is I'm going to be asking the audience for their input on various therapeutics.
Okay.
Let's see who else we have here. Any familiar faces? Is that Dr. Patel I hear?
Sounds like Dr. Patel.
She's hit the snooze button.
Mhm.
What about Dr. Drago? I see Dr. Drago here. Can we get him to chime in?
Hello, it's
Oh,
How are you?
Dr. Patel, there's an
Yeah.
interactive lesson here. Would you like to be on the list? Expert opinion.
I will be given one to weigh the clinical opinion on each of therapy.
Go ahead. Yeah.
If I'm around, then I will do it.
Oh, good. Okay, so we at least got two others other than myself. What about Dr. Drago? Will you chime in?
Hey, I actually looked some of this stuff up today because I had a patient come in just like this today. And yeah, so I have a couple little pearls. Yeah, I'm happy to talk a little bit about it.
Dr. Drago. David Villas here is a little bit of a background feedback from one of you guys.
I thought, oh no, yes. Was I missing something?
I don't know. I'm not sure what that was. I know. So with that, sounds like somebody's garbage.
I think it's Michael Gerber.
Hi.
That Dr. Gerber.
Hi, yeah. I don't know how to sign in on your deal.
Wow, Michael Gerber's voice is coming all scratchy. All right, let's just mute him. Let me see if I can mute him. Maybe Bill Clearfield can mute him.
I got it.
All right, very good. So we're going to go through each one of these therapeutics and just talk about them. So we're going to talk, first up comes ivermectin. Best use I've found is early in the treatment of COVID and viral illnesses. It was repurposed for COVID. Some patients will ask me, well, does this work for other viruses? Well, it was well, we learned about it from its application potentially in other viruses. Dosing 0.4 milligrams per kilogram for acute treatment, up to 0.6 milligrams per kilogram. Prophylactic dose is 0.2 milligrams per kilogram. My clinical experience is that it works best in early treatment. I've used it quite often, like primary care, urgent care settings. I've never used it in any severe, like hospital type of settings. And I think that most of the studies show that once you get to the hospital and you're that sick, it doesn't work that well. Side effects that I found is ocular disturbances, specifically at high dosing. I once took 56 milligrams myself, woke up the next morning, and it looked like the movie Himmel über Berlin, which is a German movie filmed in black and white. You know, everything looked gray. So toxic dose ocular disturbances, transient for the most part. Other findings I've learned about ivermectin is we're repurposing it for the treatment of prostate cancer and enlarged prostate, and it seems to work very well for this condition in combination with lactoferrin. Other things I've found is that it can help with inflammatory conditions. I've had patients with migraine headaches, arthritis, these clear up, and in one case, IBS clear up, but I think this patient dealt with a parasite and just incidentally, the ivermectin treated the parasite. Availability, compounding pharmacies are most affordable for high dosing. Mechanisms, we can get more into that a little bit later. But I'd like to ask some of the audience here if they'd like to add anything to the chart here for ivermectin. What have you found?
I had a friend actually who had seizures. And I thought he may have some parasites because it looks like some children with a seizure activity may have some parasitic infection. So I told him to use that and he did, but I don't know the outcome if the seizure stopped or what happened to him. But yeah, that was the only experience I have. I never used it for COVID.
So you've used it for treating parasites.
Right.
Uh-huh.
Can you tell a little bit more about what was your experience in prostate cancer patients?
Yeah, that's a whole lecture. You may have missed that one. We're hopefully going to be doing a part 2 on that one next month. But yeah, basically it's called the Prostate Community Trial, and it's a global trial not sponsored by Big Pharma. We're taking patients with large prostate and quite advanced prostate cancers, or any cancer at this point. It seems to be any patient with cancer is enrolled in this trial, mostly in the Philippines. We're using ivermectin 0.4 milligrams up to 0.6 milligrams plus lactoferrin about 500 milligrams to 600 milligrams twice daily, and dosing these patients over the course of a month, 2 months to see improvement.
Do we have any experience that where the prostate is removed and then they found at the time that it was a stage 4 with the some malignancy on the neck of the bladder as well as around it? Does it work in situations like that?
We have multiple patients with metastatic diseases that we've enrolled in this trial. When they're metastatic, there's not too much that can be done. So I have enrolled one patient with this. However, he was an Austrian physician. He is now deceased. He died from the metastatic processes. So he came a bit too late. I think with all things, it works better if you treat it early. But he was on the conventional castration treatment, you name it, and it was not helping him.
What is the length of the trial?
The length is ongoing. We continue to enroll. We're up to at least 1,700 members in the community and probably about 100 patients in this trial.
So you have a number needed to treat?
No, we do not have that many patients enrolled to start doing statistical analysis like that. Right now, it's mostly just case control studies.
Okay. Yeah. So you have 2 groups then. You have the BPH group and the cancer group. Have you done any preliminary analysis to see if the BPH group is getting better or the And how long would it take for them to get better? Maybe a year, then a
In
year.
my experience, you'll notice if it's working within the first week of starting them on ivermectin and lactoferrin, the patient will report immediately whether it's working or not. And I found essentially 50% of the time that it works to treat their nighttime urinations frequency. It's quite striking once you start putting patients on this stuff.
Have you looked into Lactobacillus salivarius? There's quite a few reports that it's killing cancer also.
No, not familiar with that bacteria.
I'll see if I can get some information to you.
Which company makes it?
Lactoferrin, Jarrow. There's another one that makes lactoferrin as well. They're on full script.
Lactoferrin, I think also ecological formula makes it too, so.
Yeah.
But if 500 milligram in divided doses or one dose?
You take 500 twice daily.
So it's 1000 milligram per day.
Yeah. Yeah.
And ivermectin is once a day or twice a day?
Once a day.
Once a day. Thank you.
So why does it work in BPH? Is it the hypothesis is that it's due to some sort of we know it's an inflammatory process, but what is it due to? Is it a parasitic? Is it a yeast? What is it due to?
The mechanism for why it works,
Yeah.
it's quite detailed here. That's a lecture in and of itself. I know there's a lot of interest in this, not the subject of this current presentation, but this is what I'm working on for next month's lecture here on this channel. So stay tuned for that. And those are all big
We'll have
hits.
you on again, Steve. So
We'll do that next month.
we have Dr. Benoit on our website, aosrd.org. We have the original one. And I can send you the link later when we're done here if you want.
That would be great.
Yeah, that was
You know, you guys, maybe you don't know, but in Africa today, prostate cancer has become epidemic. Many men are having it and younger. So you wonder what is causing it, what is behind it. And if it's prostate enlargement, also they have that. So perhaps there's some sort of I don't know what type of infection may be driving it. And it may be interesting to find out what is causing it so then we can treat it better.
it makes sense that potentially in Africa, the etiologic cause could be parasites, and that's maybe why ivermectin works so well in certain cases.
Right.
I think it's also in the email that was sent out. If you scroll all the way down, I think the class is there still.
Yeah, we'll do another one of those soon and give you guys an update on what's going on in the trial. Hydroxychloroquine is the next therapeutic that I've used most commonly. I've probably prescribed this one thousands of times. Also ivermectin. And I found that this one has very minimal side effects. I don't know if anyone has ever noticed a side effect on hydroxychloroquine. I've used it early in viral treatment alone or in combination with ivermectin, the dosing 400 milligrams on the first day and then 200 milligrams twice daily for about 10 days or until they're better. Yeah, of course, works great for arthritis and lupus. It's the known anti-malarial. It's very cheap. Anyone else have any comments on hydroxychloroquine, their experience with this?
This is Dr. Patel, and I use hydroxychloroquine in patients, those who are suffering from arthritis, Lyme arthritis, and not just the arthritis, but also from arthralgia. And when you treat it with the azithromycin, we have a very good results. So this is something to keep in mind, that they don't have lupus, they don't have just the plain arthritis, but they have Lyme arthralgia before the arthritis sets in. So that we have a very good results with that.
Oh, fantastic. How long do you treat these Lyme arthritis?
See, the Lyme arthritis is a long protocol, but Lyme arthralgia, usually if you give it for 3 months, and usually when I I started, I have the patients have the clinical examination of their eye. So that is one of the very important things because we don't know how long we are going to use it. And we don't want to have the toxicity pattern. So once the the eye exam is done, and then every 6 months, if we have continued it, otherwise they don't have to go. But occasionally we do have to give it more than 6 months.
Have you ever seen hydroxychloroquine toxicity of the eye and tape them off?
I mean, it is documented and legally, if patient develops it, we are responsible if we don't do anything about it. So anytime any patient I start them on, get them eye examination and to make sure that they have normal evaluation.
Yeah. That's fantastic. And any comment on the mechanism for why it works for these arthritic conditions?
I think when I use it with azithromycin, and it works better because it somehow have a higher rate of killing the bacteria.
Okay. Good.
Spirochetes, I mean, you know.
Spirochetes, yeah. I wish we had Dr. Halasa here who could comment on methylene blue. I personally have not used it that much in viral treatment, maybe a handful of times. It helps some patients feel very good. Some patients will feel energized and mental clarity brightens up. This is just a handful of cases though. Has anyone else used this more than me?
Well,
Yes, I have one suggestions. Anytime one plans to use the methylene blue by the intravenous route, make sure in this society one inquires about the use of the antidepressant and SSRI, as well as the SSNI and venofluxacin and etc., because they have a higher incidence of developing the serotonergic toxic effect. So that's number one. Number two is I have used more in a fungal infection, in a mold toxicity, and also in a patient suffering from the Lyme disease. Because when we do the intravenous infusion, and after that we expose them to the whole body red light laser with the also the infrared laser wavelength, these patients really improve, and many times they do have a Hertz reaction. They may develop fever, but if they don't have a hypertension, then you know it is not a serotonin toxic effect. It can be the Hertz reaction.
Yeah, the Hertz reaction can be significant. So you like the IV route? That's kind of expensive.
Yeah, IV route is expensive, but when we are talking about the oral methylene blue and IV methylene blue, it's uncomparable.
Wow.
So we are just comparing apples and oranges.
Wow.
It is that much different in the onset of the effect, as well as the extent and the effectiveness.
Okay. That's good to know. Anyone else experienced with methylene blue and has seen this IV potency?
Sometimes if you give the IV methylene blue and follow it with the IV vitamin C, you have a synergistic effect.
Yeah.
And we have found that our patients getting better faster.
Okay.
Yeah, I can speak to it. The methylene blue.
Yeah.
And sorry, I just got on the call here, so I'm just getting caught up. And I do want to comment on ivermectin. I believe you were talking about the effects on cancer.
Yes.
Okay. So yeah, so the methylene blue, I had the best case, and this was early on. This was actually back in 2021, where a patient, actually friend and patient, her husband had severe COVID to the point where he was unable to get off the couch. Okay, he was about 70 years old, 72, I think, and definitely short of breath, but refusing to go to the hospital. And he had already received some of the other treatments that she had ordered, that she had around. She actually had glutathione, thymosin alpha, had been giving him methylene blue swishes or mouth swishes with a oral red light, and was maintaining everything as far as his temperature, his status in general. But then she got really nervous and concerned. And then I actually drove over to their place with, all of my equipment and gave him an IV of methylene blue. I believe it was, I'd have to check. I think it was 10 milligrams through the IV, because I think it's 10 milligrams per cc. I may have actually given him more. I'll actually go back into the case study. And I also gave him IV glutathione and vitamin C, but I had also had a very bright light that I shined on his chest. And it was actually a light that she had because at the time I didn't actually have the red light on me that I needed. And literally, I would say after we were done with this treatment, he was standing up, having a conversation, looking normal, and he maintained that status actually for about a day. And he did start to slip again. And we had actually ordered him some concentrated oxygen or one of those devices, and it wasn't working. I guess she couldn't get it to work, and she got concerned, and he went to the hospital, ended up getting some IV steroids. They asked him why his mouth was blue. I think he said something about the methylene blue, and they kind of scratched their heads. And but he actually pulled through, and the wife had actually asked the attending, how did he do in general? And she said, and they were just amazed. They said, yeah, of everybody on this floor, I mean, first of all, he made it. Number two, he did so much better than everybody else. Okay, so that was the first time I was put in a situation that was more of a acute setting. He was definitely having a cytokine storm. I gave all the things I had at my disposal, but these are difficult to treat. I mean, once you're in that state, but it was the fact that we gave him the IV methylene blue and the light therapy, and he went from laying on the couch and basically being, I wouldn't say lethargic, but not really with it, to standing up and having a conversation. I'm sure that the glutathione and the vitamin C contributed as well. So that's why I've always felt that methylene blue, it really works its magic in those acute situations, and then subacute situations. Even my mother's husband had COVID, I believe it was 2 winters ago, and I believe it was the Delta variant. And if I go back and think about his symptoms, it was more of the just feeling like he was hit by a truck, a lot of coughing. He's not the type of person he doesn't have the allergic type symptoms that you would think of. And so he was stable and not needing, really advanced care. Well, we gave him 1 glass of methylene blue. First, he kind of was curious, like, what is this stuff? This blue drink you're giving me. But he still talks about it to this day, that soon after he took the glass, and I forget, I think we probably gave about 10 milligrams inside of that glass of water. And I believe we gave him the mouth light. as well. That's what we had at the time. And he said as soon as he did that, he felt better. And, he went on to get over, this variant, whatever he had. But my
This
point
was
is,
IV or oral? I missed-
this was oral. So I guess that's not really an IV situation, but my point is it seems to work really good in those subacute and acute situations. And I do love it in using it prophylactically because we don't know what's coming at us next. And especially if you're somebody who has, more of the allergic tendency or a poor methylator, something, again, I think we should have a talk on. Some people are more vulnerable to the effects of COVID than others. That's one thing I've noticed. And I believe it has to do with epigenetics. But just having it in my system makes me feel secure that I won't get blindsided by the next variant or the next virus or the next whatever that gets sent our way. Number two, when you have lymphopenia, which is something that I have, at least as far as the last lymphocyte map that I had, well, the way that I'm intuiting it, and I've seen this with my patients, is that as soon as your lymphocytes go down, well, something else goes up. And in my opinion, that could be fungal overgrowth of the microbiome, even skin fungal overgrowth. All right. I even noticed that I was developing onychomycosis.
Ooh.
Okay, that's a sign. Onychomycosis. The timing is pretty impeccable. And then it makes me wonder if there isn't an increase in parasites. You know what I mean? And I believe there was an article I read that COVID in general does disrupt the microbiome and favors fungal overgrowth and possibly parasitic overgrowth. But my point is having, especially if you're chronically lymphopenic. Now I haven't checked it in a while, so I don't know where I stand. But even if I was suboptimal, the idea of having methylene blue on board on a somewhat regular basis, twice a day at a low dose, gives me the reassurance that I'm keeping opportunistic pathogens perhaps under control. Now, I don't have any data to support this. I haven't tested myself, and I can't show you a before and after or what it would be, but that seems to be the case. That's why I take it on a regular basis for that reassurance.
You take
And plus it's
blue regularly?
Yeah, I take it 5 milligrams twice a day, just orally. Occasionally I miss a dose, and that's okay. But yeah, I take it twice a day. But it's also been shown to be neuroprotective. All right, and quite honestly, again, I believe I'm one of those vulnerable COVID people epigenetically. If I look at my dirty genes on a epigenetic test, it's like all of my dirty genes became active as soon as this whole COVID phenomena happened, including genes that are, I would say, connected to an increased incidence of Parkinson's and dementia, which makes me open to the possibility that my symptoms of long COVID may not necessarily be long COVID. It may be the beginning or the signs of early dementia and Parkinsonism.
Yeah, I agree that I've seen that multiple times, and I have a lecture on that as well, of how I think the COVID and the vaccines, they essentially accelerate disease illnesses, and they just make them appear earlier, and that's what it is, right?
Awesome. Yeah, I'm glad that you said that.
James, it will be
Yes.
a good idea for you to give a report that the use of methylene blue and whatever dosage you've been using, 5 or 10 milligram per day, and the long-term effect, because it is very important. It is not existing in the literature currently, and it may be of a great use. And one point I want to agree with you that it's one of the very good molecule to be used in patients with cancer, particularly giving the photodynamic treatment. So you can really destroy it very well when it gets concentrated into the cancer tissue. And I have a lecture on that, the photodynamic treatment and giving the methylene blue
Yeah.
and creating the hypochlorite molecule and destroying the cancer cells. So that is, yeah, and you can use in any type of cancer. Another thing is that it does also immunomodulation. So besides having the buffering effect, so it is important that we have not encountered this use in patients, but in order to give the photodynamic treatment with the hyperthermia, you have to have a right unit to give regular this red light therapy is not going to work. One has to have the deep penetrating intensity of the red light to be given to have the optimal effect.
So
And
you're talking about those red lights with the
with the hyperthermia,
prongs?
right?
With with the prongs. I mean, the one that clips on
Not with the
to like.
prongs, no. I mean, it may help for the COVID infection, but if you have a cancer, those red prongs are not going to be effective.
Oh, okay. You're talking about then maybe fiber optic.
Yeah, you can use fiber optic. It's even much more than you are giving with the hyperthermia, because fiber optic does not deliver as much of a hyperthermia. So we have a unit specially made for us, and we deliver that hyperthermia along with the variable different spectrum of the light. So it has
Okay.
a 550, it has a 660, it has a 980, and then it has a 1090. So
Okay, so that
all different variable wavelength.
so this is a different light that you have we haven't
it's
really.
not available commercially. You have to have it, get it commercial, made it by the specialty service people.
Yeah, I think that's a great point, because I just suddenly remembered a couple other cases. I'll just talk just a little bit about them. Not long. I had a patient's, or it was actually a friend of a friend's mother, who was severely ill from rectal cancer. And in fact, she had basically moved into her mother's place on a whim. Sorry, the mother had moved into her daughter's place on a whim and was declining quickly, and absolutely was not going to go to the hospital. So I show up. This was in a high rise, and I actually have a photo of it. And she wasn't eating, and she was dehydrated, and she was laying in the bed, really just in pain, and I would say half conscious, and not looking good. Like, wasn't going to make it through the night. But they didn't have any pain meds. They didn't have hospice or anything at their disposal. And so I had the methylene blue. I actually drew a little blood. It spun out the platelets, did the sonification of the platelets to get them to break up their cell walls and to release their nanoparticles, loaded them with methylene blue. Okay, that's something that we learned, and was able to put an IV in, and along with some IV fluids, very slowly, because she was third spacing at the same time, gave her the loaded platelet-derived nanoparticles with methylene blue. I had the red light, at least the one that does penetrate deeper than just the skin devices, we'll say. It was a much more narrow penetrating light, with the 2 prongs and shined it on her abdomen in all the places that I knew that there were metastases, like the liver, the rectal area, and did that for a good, slow IV drip, and did that for about an hour, if not more. And she perked up. Okay. And I think the point is to not see everything as did it heal her completely? Is she alive? Is she not alive? To realize that that's a place where we bought her some time, because we didn't know if she was going to make it through the night. I mean, she was turning kind of hypothermic. And she perked up enough that she was able to get through the night. And then she woke up, and the daughter said that she actually got out of bed and walked to the restroom to use the restroom. And so that gave us enough time to get hospice on the case and have her evaluated and have her with a bedside commode and pain meds and a nurse coming in on a regular basis. And actually bought them enough time because we continued to do treatments 2 times per week. So this went on for about a month, and they had enough time to fly in family members. You know what I mean? So this is where, again, it's like, even if you're like, well, I don't know if there's enough studies to do this and whatever, did it work? Did it not work? Well, it definitely bought us some time. And I think that's the point. The other case was a 33-year-old.
Dr.
Yeah.
Patel, okay, 1 minute. I have a question regarding when you gave nanoparticle and methylene blue. Did you filter it, or did you give without filter?
No, I filtered it. So I had the.
If you filtered it, it's impossible to get the methylene blue good amount through the filter, and that's my personal experience in hundreds of cases. So now I add it later on.
Oh, okay. No, that's a good point. I mean,
Unless you put 1 milligram or 2 milligram, it's a different story. But now what I do is I add methylene blue in the bag, and then I just do the nanoparticle filtering, and then do it sonicated, of course. And you can put also the thymosin alpha with that. So thymosin alpha will be, because and most of the cancers, thymosin alpha has a very good results. So if you want to deliver that way, you can put the thymosin alpha. I know you were just there, and these are the only molecules that you had with you. But I'm just adding one more point that you can add thymosin alpha nanoparticles, and you can.
That's great. We're going to get the thymosin alpha a little bit later. I have a slide on that one.
Yeah. And I mean, obviously methylene blue still got filtered because the solution was, the IV solution was still blue, but that's a great point. And when I think about it, it was, was it dark blue or was it light blue? And I recall it being light blue. So obviously
clogged. That is my point. The filters get clogged. So then even for 1 ml, you may end up using 4 or 5 filters, and it's not enough. So.
Hello?
Yeah, she muted herself.
Oh, okay. And so, okay. So some of the methylene blue got in, but that's a great point, that not all of it. So that's something we need to be conscious of, obviously. And then the other case was a 33-year-old male who he had actually had a thrombosis from COVID, from a cytokine storm. Now he had also had a history of some amphetamine use, and which explains some of his presentation. He had severe cardiomyopathy. He had a small stroke. He actually had a DVT, femoral DVT, and he basically went into cardiopulmonary arrest, was in the ICU, but he was left with about 9% ejection fraction. And then because he had also had a thrombus in the left ventricle. He had been medvaced from, I believe it was from Latin America. I can't think of the country, and medvac to Michigan. And I met him 2 weeks after he was out of the hospital in Grand Rapids, Michigan. And he had about 15% ejection fraction, and he was on a midodrine drip, really to continue the pumping action of the heart, so he could actually sit at home and wait for some sort of a heart transplant of some sort, actually partial mechanical heart transplant. And he had done his research and said he wanted to try the regenerative route, and had a connection through his sister, through somebody, and then they contacted me. I went over to his house about 2 days later with his family. They had terror in their eyes. And we did the methylene blue loaded nanoparticles, and we had actually done the placental derived exosomes, loaded them with the methylene blue. We had the lights shined right at his heart area. So we don't know how much of, did it really affect the heart, the light? Obviously I'd like the idea of these more advanced lights. But the idea was to at least have enough heat to attract the nanoparticles, to absorb through the heart wall on the inside to get into the muscle in order to buffer the redox and to enhance regeneration, reduce scar tissue formation, because that was really the main concern. But again, to enhance muscle healing, regeneration, reduction in scar tissue. And this was like an incredible case. Now his age obviously helped, but he ended up slowly improving, getting off the midodrine drip. And we had also put thymosin beta in that cocktail as well, that I remember. And I did a tune-up on him. He showed up at my condo, literally did his first road trip, something like 6 months afterwards, and to visit a friend. It was the first time he did a road trip, and actually came over to my condo. I did a tune-up on him, did essentially the same treatment. And at about 1 year, his ejection fraction was, the last I heard, it was 49%. I mean, that basically, that's a normal life, because I believe 55 is the upper low end of normal, 55%.
Yeah.
So, and that's the case. Now, I was told by a cardiovascular surgeon that I respected that, oh no, they say he's not going to make it. There's no way he can make it. Well, he did. Not only did he, but he's thriving. Okay. So again, I don't have 1,000 cases to compare with. I'm not trying to exaggerate or get overly excited. I mean, believe me, it's exciting to have that kind of a result and to be the hero for somebody like that. But see, that's a case with methylene blue, photodynamic therapy in a different context. And he did methylene blue every day, twice a day after that treatment, because you got to buffer the redox. You have to enhance mitochondrial function. You have to help the mitochondria to form water from oxygen. That's the last step of oxidative phosphorylation before ATP production. If you don't do this stuff, what chance do you have? So those are amazing case. That's methylene blue at its finest.
Yeah, that's impressive. Good. Yeah. We'll move
Oh,
on.
and then really quick, ivermectin. The cancer protective effects are through, because from the lecture last night, it's one, the mechanism is the blocking of PAC1, and I forget what it stands for. It's probably another protein kinase, but in cancer cells, it leads to activation of AKT, or really it's mTOR signaling. And by ivermectin induces the degradation of PAC1, that leads to the inactivation of the mTOR signaling, subsequently inducing autophagy. And that leads to, I believe, apoptosis of the cancer cell versus leading to all the other things. So that's the basics of, so there is a specific mechanism of ivermectin versus just parasitic, control.
Awesome. I like that. Good. This is what I've been using more recently is N-acetylcysteine for nebulization. I've been using it often for congested individuals, in particular the children who are always getting congestion, and you want to avoid the antibiosis in the children. I find you nebulize the N-acetylcysteine. It comes in a vial, about 30 mLs, 20 milligrams per ml. You can do like 2-3 mLs, have them nebulize that, and their congestion clears up very well. Also, the asthmatic children, you read the literature and it says they're going to get bronchospasm. You shouldn't use it. It's not true. I've used it for the most part. They're perfect. And we always have the albuterol on hand, but they actually improve tremendously, these asthmatic children. I use it a lot in asthmatic children, and they do very well with nebulized N-acetylcysteine. Have you all used this much nebulization form? I know we use it IV, of course.
We use the N-acetylcysteine when we are doing the nanoparticle treatment for cancer patients, and N-acetylcysteine has an antifibrotic activity. So when we have a patient with cancer, usually there is the problem with the fibrosis is very common, and particularly ovarian cancer, certain degree of the nodular sclerosis, wherever in the lung cancer. So it is very helpful to use when Dr. Joseph already described that you take the platelets and you do sonication, and after sonication, you do the filtration. But after you do the PRP and before you make the sonication, at that time after you do the sonication and before you do different waves treatment, you add TA1, you add other thing, N-acetylcysteine, and also the other molecules, whichever molecules you think is needed after looking at the whole patient spectrum, the blood analysis. And after blood analysis is, one decides before you do the nanoparticle treatment, you prepare all of these different molecules to be added and integrated into the nanoparticle capsules. And after that, it is also filtered, and then it is injected.
Injected IV, or how do you inject it?
Yes. You can inject directly. I had some patient of squamous cell carcinoma, and of the face, and I did inject directly into the tumor.
Oh, fantastic. You're quite contrary to most people in integrative medicine who say don't use glutathione and NAC in cancer.
I do not use glutathione.
You use NAC?
No, I do not use glutathione in my patient, but I have NAC works differently in cancer patient. It just doesn't get directly converted into glutathione. So if one thinks, because it has to have a tripeptide in order to go into glutathione phase. So before it goes into tripeptide phase, it is being utilized and it is being encapsulated, so nothing else gets into it. So and glutathione, I do not use it because there is a controversy, but I think when patient is immensely emaciated, glutathione may work, because when chemotherapy fails and everything else fails, and at that point, patient is really malnourished. And I mean, I have a few cases in, and I have tried it, and I have one case that I have used nothing but glutathione, NAD, and vitamin C, and red light, constant red light treatment during the therapy, along with, of course, ozone, but I don't think ozone was partly responsible. But she is 5 years into remission, stage 4 breast cancer.
Impressive.
So I mean, I can, and at that time I was not using methylene blue or anything, but NAD, I still use it, but I do not use glutathione unless the patient is very emaciated or something, because it is a double-edged sword. That's how I think. It may help in a mitophagy, I think, more than, so one cannot completely discard that molecule, but in a fairly healthy looking patient who has gotten just the chemotherapy and the tumor is not responding, I would not use glutathione at that pace.
Okay, all right, just clearing that up. Good. Let's see. Corticosteroids, we all know about these. We've used them extensively in the pandemic for the treatment of COVID. Medrol Dospex, prednisones, Solumedrol, if you have them in your office, you can give them IM. Hydrocortisone, the more bioidentical versions, I find that more tolerable for some patients, less sensitivities. And some people have very high sensitivity to the PEGs, like polyethylene glycol. I've had some patients have sensitivities to that who have some vaccine injury. Anyone want to comment on corticosteroid use, their experience with this over the pandemic?
Yeah, I'll just mention a couple of things about it, because I had to work things out in my mind, like, well, why this, why the steroids, why methylene blue? And the thing that really stands out, I did treat a patient, it wasn't with IV Solumedrol, but it was with the Medrol Dospex. That was the same patient that I went over, who was having sort of a subacute cytokine storm. And the reality is the steroids were given before I had gotten there. But it definitely was part of the stabilization process. The thing of it is think about it this way. Obviously, we have to dampen the inflammatory response as well as buffer the redox. The thing of it is it takes time. The inflammatory response, as I've sort of worked it in my mind, first it's oxidative stress, which triggers the inflammatory cytokines out of control, at least in COVID situation, activating polarizing the immune system. And when you're trying to reduce inflammation, it takes time to do that. But when you're buffering the redox, it's happening right away. And so I didn't mention this with methylene blue, but what you're effectively doing, besides helping, with the light to kill the virus, because it stains the virus and it gets into the viral RNA, and then the light hits the methylene blue, triggering, exciting it, or triggering, almost like dynamite, triggers an oxidative burst that damages the viral RNA. Okay, that's how that works. That actually slips into the viral RNA like a disc into the coil. That's how they describe it, intercalates. That's the technical term. But the main thing is you're reversing the Warburg effect on the mitochondria. The mitochondria shuts down, and when the body's in a cytokine storm, you're only utilizing glycolysis, and oxidative stress is building up, and that's why the people are short of breath without being short of breath. I mean, that's part of the reason, because they cannot undergo oxidative phosphorylation. Well, the methylene blue and the light gets absorbed by the mitochondria as well, the cytochrome oxidase C, But the methylene blue reverses that effect, and it does it instantly. Okay, so that's why that's so important. That's the first thing, and that's why the patient was up and standing right after the IV. But and then of course he had to go to the hospital, after he slipped a couple days later. He had to go to the hospital, and he got the IV Solumedrol. But when I think about what comes first, what comes next, buffering the redox is the first thing. The steroids will kick in later, and obviously the most important thing, it's going to dampen the immune response in general, but it's the cytokine storm that's going to cause death.
So you
that's-
combine both
that's my
together?
take. Well, in that situation, I didn't have Solumedrol, but I had done 2 Medrol dose packs, I believe 2 weeks prior to me actually having to come over to the house and give the IV methylene blue. So all the things I was doing, at least from a distance, was dampening and holding everything off. It's just he continued to progress to a point where even that wasn't enough. But think about it. We didn't have him on IV Solumedrol, but I didn't have it. Number 2, he didn't want to go to the hospital. And had he done the IV Solumedrol, say if I had right at the beginning, like IV methylene blue and IV Solumedrol at the same time, well, after the methylene blue, you may have had an immediate response from that, but the Solumedrol would have kicked in. Or say if I would have done it actually when I did the treatment, he may not have bounced or declined 2 days later, because the Solumedrol would have kicked in. And we know this because he went to the hospital, got the IV Solumedrol, and then made it. So yeah.
In our practice, we did use during the COVID times the IV Solumedrol along with the Zithromax. Zithromax it also reduces the inflammation, and we did the ozone treatment simultaneously, and followed by the vitamin C IV. And our patients did well. They did not need hospitalization. They were advised to go to the hospital, but their saturation was still enough, and they came to our office, and we provided them the treatment. We had after our normal office hours, we had a COVID hours, and during that time we treated our patients, and unfortunately most of the patients did well. But I was using the azithromycin along with the Solumedrol. And of course, I was using all other treatment, like we were using the ivermectin, we were using the, if patients were able to get sometime Plaquenil, hydroxychloroquine, we were giving that, or we were giving ivermectin. In our area, and methylene blue, it takes about 48 hours to get that from the pharmacy. So until then, we stabilized the patients with these and then added the other treatment.
And I was going to add, and if you're concerned about, well, what about immunosuppressant? Well, first of all, again, you're trying to dampen the inflammation is the most important thing. That's what we learned.
Yes, you're right.
But we can still give the thymosin alpha to help upregulate the T cells.
It doesn't work as fast, unless you give it a super high doses.
Yeah, that's what it's seeing. Yeah, okay, no, that's a great point. And again, it's like, okay, then what has precedence then? Yeah, obviously buffer the redox, get the steroids going. It's going to take time to kick in. Don't worry about.
We have a IV methylene blue at the time available. So if we had IV methylene blue, we would have treated patients really well with the IV methylene blue and put them in the whole body red, laser.
Yeah.
For the photobiomodulation treatment, along with the virucidal effect. So it would have done great, but you are dealing with whatever is available to you at the time when you're treating the patient.
Yeah,
Yeah.
and that makes sense. And that makes sense. That the time frame, the thymus and alpha would take longer because that's you're actually having to activate the thymus gland to, produce more T cells, and that's a even longer process. At least the studies I saw were, yes, it improved the mortality rate of the first 30 days of hospitalization. But that's 30 days. Versus, okay, what about the first week? Now, I mean, we don't have I didn't see anything on it, but I would think that the steroids would be the most important thing, for day
Life-saving measure.
yeah, like day 2, I mean, putting it on board right away, knowing that it's going to kick in about 24 hours and then for the next week or so. And then you've got the, at least protecting the immune system with the thymus and alpha, and then of course buffering the redox the whole time, and killing the virus. I mean, it's brilliant.
Dr. Patel, have you used your protocol in long COVID syndrome?
I'm sorry, and nephrotic syndrome? No, unfortunately, I don't see any patients with nephrotic syndrome.
No, I said long COVID syndrome.
Oh, long COVID syndrome, yes. I have used it, but again, I don't see as many patients with long COVID syndrome in my practice.
Hmm.
But wherever I have used it, it has helped them. But
What
I
are you
mean, I
using?
think long COVID syndrome is a spectrum.
Right.
And at what manifestation, which organ system is involved, and sometimes they have a GI system involved because their vagus nerve is involved. Sometimes they have more of a problems with the brain, and you can call early dementia or whatever. And it is very hard, no matter what you have tried. We can say, oh, this helps, that helps, but I have not seen the the patient may say that patient is getting better, but I mean, clinically, I cannot 100% say that patient is better. So if anybody has a better outcome so far, the COVID-induced the early dementia, I would like to know about that, because I have a few patients with COVID vaccine and Parkinson's, early Parkinsonian disease. I mean, they are really suffering.
Dr. Patel, so is it safe to say, in your opinion, now this was sort of an epiphany from that I had last night, okay, is it possible, like I said, I went over my epigenetics and I realized all of the predispositions that I had became active after COVID, okay, or actually just during the COVID period. And like you said, it's not like it went away after a certain amount of time. I've kept it under control, but that's why it seems like, they couldn't figure out what's this long COVID, and it's different, and they found 200 or 3 different symptoms that people complained of. What if it's actually activating, turning on all of those predispositions that maybe you wouldn't get for maybe another 10, 15 years or until you're older or whatever. And basically it's like flip them all on, turn them all on. And depending on how old you are, and how, if your gene is homozygous versus heterozygous, this dysfunctional gene, depending on how old you are, is how severe, in a sense, that you'll present. So somebody who's 30 who cannot quite get over the brain fog and say they've got the methylation issues, history of psoriasis, detoxification issues, dysfunctional glutathione genes, and that what they really have actually at the age of 30, say 36 years old, is an early dementia of Parkinson's. It's like the gene got turned on. Now they have it.
Precisely.
But
That's
how
what
can you reverse it? Because if it in early stage, you can reverse it. If it is early stage, and if you realize that something is wrong because it has not become the fixed disease, and during the journey of that, I mean, if we find the real cause and the treatment, we should be able to reverse it.
Well, yeah. Well, how about this? Okay, the challenge is that then there's another variant, and then so maybe there was some progress made, and then boom, they're right back where they started, or they start presenting with other things. Their toxic load starts, they have a toxic burden. And like you said, Dr. Patel, the straw that broke the camel's back, all of a sudden, the mold toxicity that you didn't realize you had is now affecting you, especially if there's some lymphopenia involved. There may be some heavy metal toxicity. There's 5G, and so on top of COVID.
I have gone through all of that. Okay, I have gone through all of that. And looked at every single cause, and still not being. I mean, I may be able to reverse it, but then in 6 months they are back to where. I mean, then there was like no progress, and
Okay, so are you saying
that's not the usual step ladder pattern progress you see? It's not there.
Okay, so perhaps there's this constant reactivation, and so it seems like you can't get rid of it because it's being reactivated every time we make a little progress. Or this is another theory I've been working on. Maybe there are other genes that are involved that, obviously when somebody has that
we need a really brainstorming and find out, let's do this genetic map, let's do this, let's do that. And a few of us work together on these difficult patients with the understanding that patient understands that we are working hard to make them better. We don't know where we are going to end up. So, we are not building up a big hope, and at the same time we are treating in a cost-effective manner. Then we can see that whether we are arriving at some point that is acceptable.
I like that. That sounds great.
Yeah, because the reason why I say this, it may be more complex in the sense that, first of all, you're having a lot of things happening at once, and perhaps this is this is the aging process accelerated, 10 times, and that you've suddenly found yourself not in the beginning stage of a disease, but somewhere 25 or maybe halfway through the disease. And no, do we reverse dementia when it's 50% into the disease state completely? Not really. We control it, we can improve it. And the other thing I want to say is as we understand aging better, again, is it possible that there are regulatory genes? The process of aging leads to certain regulatory genes that control the other genes, and that those regulatory genes turn off. And that maybe it's about turning on these regulatory genes. And there's actually names for them. There's studies going on, or have been going on, like
there are bioregulatory genes, like you were talking about the case of the heart, and there is a bioregulatory peptide that can turn around the heart failure case and low ejection fraction, that vascuogen or something, the name is there, and you can use it, and it reverses it. So I mean, but for brain, there is nothing so significant around to turn on the brain.
Yeah, I really think there could be a major issue with hormonal interplay, right? So you may have your mast cells and your basophils that are being activated by the cytokine or the immunoglobulins, especially IgG. So when you have the IgG on your mast cells and basophil, they're going to release histamine and all these other things that they have inside, and that causes multiple reaction. The histamine alone, if you look at the reaction that it causes, they affect everything, the heart, the brain, everything. And so if you talk about brain fog, it could be maybe lack of testosterone, too much estrogens. I mean, there's a whole lot of things that are causing all these problems. So you have to really look at it holistically, completely. That is where we unravel the functional medicine to figure out what is really happening to these patients.
Yeah, that's what I
Yeah,
found.
and-
Yeah,
Yeah, and I couldn't-
assumption, lack of vitamins, lack of nutrients. There's a lot of reasons for it, and then the COVID accelerated it.
Right.
Yeah, absolutely. And of course, modulating the mast cells. I mean, I know that's one that we've really focused in on. And I did listen to your lecture, which was great because it was really in depth, but it also showed how important the mast cells were, and the differences between male and female because of hormonal differences. And there's so much more, but yeah, I guess that's what I'm trying to say. I guess number one, that's why it's so complex and complicated, because there's so many working parts going on at the same time. And then I was sort of getting ahead of myself, or getting ahead of sort of a lot of these concepts, and suggesting, hey, at the end of the day, what if we're dealing with what they call Yamanaka factors, and this is something I'm working on, where they're talking about reversing aging with these factors are a set of genes that sort of control all the other genes, and that if those get shut off as part of the aging process, and say with all these things that are going on, these regulatory genes are getting prematurely turned off, then what if at the end of the day we modulate everything that we can, but we may need to have a strategy to flip those genes, those Yamanaka genes on again. And again, I'm saying it more to not to prove that Yamanaka genes are the answer, more so to say maybe this is how deep we're going to end up having to go in order to actually fully recover from, or the people who are dealing with this to fully recover from these different variations on these syndromes.
Has anybody actually used antifungals in combination with all of these and see results?
Well, yeah, there's results. Absolutely. I'm a big fan of antifungals, and realizing that, hey, that's a big one, that I think it's a big elephant in the room as well, that fungal overgrowth is happening, and that's a bigger piece of the aging process than is obvious, and that we're not really taught this either. But I'm talking about the cases. I'm theoretically, I'm saying, look, if we were to fix everything, the fungus, the mast cells, give all the right peptides that we think that we need, but they're still not better. And that's what I think Dr. Patel is talking about, that then is there another level where this may end up being, more a gene sort of thing, where we have to flip on regulatory genes that have been turned off. So I'm just taking things to the extreme, but I'm imagining this to be the case because this long COVID, these confusing long COVID syndromes, some of them are seemingly impossible to treat, even if we're addressing, all the issues that we think are going on.
Excellent. Good. And now has Dr. Patel, you mentioned using thymosin alpha-1 IV. Where are you finding IV TA1? Because I can only get a sub-Q injections of this stuff.
I'm using mainly when I'm doing the nanoparticle, then I can deliver it in the capsules. So it gets delivered where there is inflammation and where it is needed, instead of going in every tissue in a larger concentration. So I mean, this is the way you can treat your Epstein-Barr very effectively in acute when they have a very chronic fatigue. And sometime you can also give the interferon alpha along with that, so it can increases the activity, because it is in the B cells more affected than the T cells.
Where are you sourcing your thymosin alpha-1 right now?
We have a multiple different
Okay, good.
sources.
That's good to know. Cool. All right. Azithromycin, we all know about this one. I've used this extensively in the pandemic. 500 milligrams daily for about 5 days for severe COVID. I've never noticed any side effects with this one, maybe some GI upset. Typically, I find this milder on the GI system than most.
But not to use azithromycin and hydroxychloroquine together.
Weren't you doing that? Is that what you mentioned? You're using for Lyme?
No, not hydroxychloroquine. Yeah, I did mention in one, but you have to be very careful about when you're using it, but to check with the patient if patient has any of the irregularity in their heartbeat. And we do the heart rate variability test, so we know where the patient is, and also let the patient know that if you have any problem in the like tachycardia or missing weight or anything like that, then let us know.
Okay.
So one has to be very careful
Right.
if they are using together.
Have you noticed that? Because you're using it
But
long.
I had a patient when I was using, so I have been very careful about it.
So this happened in one of your Lyme cases?
Yes, one of my Lyme cases.
If you use that azithromycin with, say, fluconazole, that can also happen that same way with the heart.
Okay. Makes sense. Very good. Doxycycline. I've used this one as well extensively in COVID. A lot of people like this. It's anti-inflammatory, especially the chronic bronchitis. They say, doc, it's the only thing that ever helped me. Give me the doxycycline. You've probably heard that before, right? Why is that, right? It helps with the inflammation of the lung.
The question is why all the medications that treat malaria are so effective in COVID?
And cancer. We should ask that as well.
That's right. We use doxycycline in cancer patients when it is used with the IV vitamin C. You give doxycycline and give IV vitamin C following. It has a very
For cancer, huh?
Anti-cancerous effect.
High dose vitamin C, like 30 grams, 50 grams.
50 grams.
So will that be more effective than just IV vitamin C?
Yeah.
Oral.
I forgot right now, but I have on my desk which pathway it goes through that it activates and how it becomes effective. I don't recall that right now, but I have that. When I tell my patients why they are going to do it, I also tell them what it does. So then they don't forget not to take it. And they usually I tell them to eat something before they take doxycycline, because on empty stomach, it has a more side effect and patient may not take it.
What about the sunlight issues with doxycycline or the tetracycline?
Oh yes, of course. But sunlight, they have to avoid it. If you are giving on intermittent basis, it's not as bad. But sunlight, some patients are very sensitive to sunlight, and I have seen first and second degree burn on it. When they say, oh, well, we didn't put these, we didn't do these because it's a cloudy day, forgetting that they can get the sunburn on cloudy day. So I also emphasize them now that if it is a cloudy day, don't think you're not going to get burned. So there are certain important informations we have to give it to patient at the time we prescribe it.
Yep. Yep. All right. Thanks. Have you guys used much true blood thinners in the pandemic? So we're talking like real deal Eliquis, Xarelto, or heparin, even as treatment or prophylaxis, even in high-risk patients.
One out of all these patients, one patient had to go on Eliquis. He complained of, he was doing fine. He was really bad case, and we made him better. He came almost for 2 weeks, and after 2 weeks, he came one day and said, I think I'm having a pain in my leg. And then I sent him immediately for DVT screen and D-dimer and that, and he was positive. So we had to, I sent him to his primary care and I put him on Eliquis because I didn't want to take care of him for his DVT because it's a long-term issue. So it's better, he's better with the primary care.
Yeah. But outpatient basic antiplatelets, and then also the fibrinolytics, the nattokinase, the lumbrokinase syrup.
Yeah, that we use routinely in all COVID patients treatment. So that if it helps in their perfusion anyhow.
It does. Yeah. I've used these extensively as well. I monitor the D-dimer. Have you all measured the D-dimer routinely in these COVID patients and long COVID patients?
In all infection patients, we do check, and not just for the D-dimer, but sometimes the TAT is positive. Sometimes we have seen prothrombin fragment 1 and 2 are positive when D-dimer is negative. So I just don't use one D-dimer as a marker.
What were these other markers you're mentioning?
Prothrombin fragment 1 and 2.
Prothrombin.
I have a whole series of different tests besides D-dimer. What else I use?
Dr. Patel, you've been hiding from us. You'd have to come back and enlighten us on your protocols.
Okay, thank you.
So we're getting some good pearls of wisdom out of her tonight.
I know you've been missed.
Yeah, well, my family commitments are so extensive these days that I'm glad that I'm attending these. I wasn't able to attend yesterday.
We're going to have Dr. Beamer on next week. For us, he's going to be doing the same. It's a repurposing of drugs for chronic disease, and he did that.
That will be good. I missed him. Yeah.
Next Tuesday, we're going to have it on. So, and we record everything and we post it, so it's always available.
I have to get the link from you. I forgot that too.
Yeah. Here's a few slides if you're curious on the mechanistic activity of the lactoferrin. I have a lot more on this subject. But lactoferrin, I've used this also in viral illnesses and cancer. It's an antiviral, like many of these other therapies. So I use it in my multi-drug protocol very routinely.
Can you go back to slide 18 real quick?
Yeah.
There we go, Pat. Yeah, right.
It's interestingly, it steals iron from iron-loving bacteria, so it could be used as a natural antibiotic for patients with. You see elevated neutrophils. You see perhaps maybe they suffer with bacterial overgrowth. You give them either the raw milk or the raw kefir, or you give them the lactoferrin, and the lactoferrin it can kill the pathogens. And regulate the reactive oxygen species system. So Dr. Halassa should look into this one. He's big in the mechanistic pathways of ROS.
What's the dose for the lactoferrin, Steve?
600 to 500 twice daily.
Okay. The Jarrow, I think, is 250 capsule.
No, it's 500, I think.
Okay.
Yeah, Jarrow's 500. But yeah, the lactoferrin is absent in most diets in both Western and Eastern countries because they pasteurize the milk, right? So it's lacking in most diets. So people don't have this molecule that it prevents cancer, it treats infections, it treats viruses. It's deficient in diet. It's gone. But it's something that we evolved with is these enzymes that are found in the fermented milks. So Dr. Joseph almost convinced me that NAD is completely out, that we have to use 5-amino-1-MQ, but I still use the precursors, NMN, NMR, and maybe NAD injections on occasion. They're not completely out for me.
NAD works pretty good. So if NAD works, why do you need a more expensive molecule?
You have to watch my lecture with Dr. Joseph. I have it on my YouTube channel. He almost convinced me. Glutathione injections, yes, IV or intramuscular or the transdermal, I think is good, or Quicksilver Scientific, the liposomal one is pretty good. Other than that, as Dr. Patel does, the N-acetylcysteine is a good precursor.
Okay, so back to the NAD plus, you really just have to think about it in simple terms. Now, the goal is to increase intracellular NAD plus because it's a master metabolic bioregulator. It's regulating sirtuin genes, it's regulating the mitochondrial function and glycolysis and citric acid cycle, literally, and the electron transport chain. It's also through activation of sirtuin 1, it's activating AMPK. It's also modulating inflammatory cytokines. It's also stimulating muscle stem cells. But this is only happening with optimal intracellular NAD plus levels. And it takes time for all of those things to happen. Okay. When you do exogenous NAD plus, there's no evidence that it actually gets into the cell. It hasn't been proven, it hasn't been shown, but you do get these immediate effects that may be coming from hormesis because it's a stress on the body. That burning sensation is a stress. Now that's just my theory. Or I heard from, again, an expert in NAD plus, PhD level, who, yes, he sells NMN, but and not NAD plus. So who knows, maybe there could be some bias, I'm open. But he thinks that NAD plus, when it's given exogenously, it acts through signal transduction. And so it acts more like a neurotransmitter, and that's why people feel better. Okay, so there's a difference between feeling better and actually optimizing intracellular levels of NAD plus, leading to all of those modulated functions of metabolism and regeneration through muscle stem cells and immune modulation and switching the metabolism into AMPK from mTOR, all these things, and autophagy. All these things are happening simultaneously. That's regenerative. That's completely different. And that's why 5-amino-1-MQ is completely different. And if you talk to people and their experiences, you'll see that at about 3 weeks, they are having results that are beyond, that are not even in the same league as NAD plus. I like NAD plus, fine. Why not do both? If it makes a person feel good, there's nothing wrong with NAD plus, but I'm talking about regenerative. I'm talking about all these other major things that are happening because of the fact that intracellular NAD plus is a master bioregulator. 5-amino-1-MQ works by opening up the salvage pathway. And it does that because in the situations that we're talking about, say, for example, either aging or long COVID, that hasn't been proven, but when somebody's is chronically ill, it's been shown in cancer, it's been shown with sarcopenia, that there's an enzyme called NNMT that blocks the salvage pathway of NAD+. So NAD+ has a salvage pathway, which is basically salvaging the components of NAD+ production. And especially if you're dealing with COVID, even in the COVID literature, NAD+ is being siphoned off, overutilized for PARP production in the DNA for DNA repair. COVID has a way of keeping PARP, actually breaking down PARP, so you have to produce more PARP in order to fix DNA breaks from oxidative stress, and it takes NAD+ to form the PARP. And so you're chronically low on NAD+, and after a while, it seems that NNMT will actually be elevated in order to prevent the buildup of some of the NAD+ byproducts. But in situations, in chronic situations, that may not be beneficial, and that by dampening the NNMT or nicotinamide N-methyltransferase, you will restore the salvage pathway of NAD+, but at the same time, you will also restore another pathway leading to increased SAM production, which is a major methylator, leading to increase in the polyamine flux, which is something I'm still learning about which leads to increased metabolism of fat, or at least turning of white fat to brown fat, apparently. And so there's a lot of things that are happening. That's a much more sophisticated route and anti-aging and regenerative and cancer preventive in many ways, and treatment of sarcopenia. That's a different ballpark than just giving NAD+. You see what I mean? So we need to do a lecture on that so that we can actually look at those mechanisms and see it and show the literature, so you're convinced that what they're feeling is different. That's not what we're trying to accomplish, but you can do both.
But James, I think there is one thing when you can use NAD+ and when you cannot use NAD+, but maybe better off using something else. Because the NAD+ has been used for a long period of time and has excellent results. So we cannot put that molecule down. We have to look where that molecule do the best and where other molecules do better. So that each one has its own place. But we cannot replace the molecule which has been used for a longer period of time in a multiple clinics around the country and having excellent results. Now, what are they treating and what are we planning to treat are two different things, but they are treating all the addiction cases. They are putting with the addiction, with the malnutrition, and they are having the excellent results with the 10 days IVs or 14 days IVs or et cetera, in a very large amount for a whole day. And so I have treated patients with COVID and other thing, and I have put the NAD+ in my vitamin C IV, and patient has, and you can go up to certain amount, and beyond that they cannot tolerate, and they definitely feel better now. And like all neurological symptoms like twitching and this and that all have disappeared in this patient. So when we do the detailed symptomatic analysis and seeing that patient getting better, we cannot neglect that molecule in right of the other molecule, which may be better on the page, where we have to build up the experience on it and then see that, okay, these are the condition, it works better compared to these conditions. And that's my recommendation.
Okay, so let me just jump in. Absolutely 100%, you're right. But I do want to say this. Those results are probably happening because it's acting as a neurotransmitter. I think it's great for addiction. I really do. I think it's great for a lot of things. I didn't say use one or another. I'm just saying they're doing two different, completely different things. So why not do both? But if you're trying to boost, if you're trying to trigger regeneration and optimize metabolism and turn on longevity genes and increase autophagy and modulate the immune system and trigger activate the muscle stem cells, that's a completely different process from calming the nerves. And,
You're absolutely right. That's what I say. That
Okay.
we have to see that NAD can work for these conditions, but 1-MNOQ is better for these following conditions. So that can give the guidance to the physicians and ourselves too, because we look at the list and we see what is better, what's not better.
Perfect.
I'll
And
give you my report. I'm testing out on a couple of patients right now with chronic fatigue post-COVID, or I'm actually seeing, get this, I don't know if you guys have seen this, but unvaccinated patients exposed to vaccinated patients getting sick with the same long COVID syndrome. Bizarre, I know.
So one question is, why wouldn't NAD plus enter the cell, Dr. Joseph? Is it because of the thickening of the mitochondria outer shell, or what is it?
No, there's no channel. I mean, when I look at the studies, there's no channel for it. I'm talking about different studies that talk about how NAD plus is built. It's actually built from niacin and from NMN, and I guess the recent studies over the past couple of years show that NMN, nicotinamide mononucleotide, is better. That's one step away from building NAD plus. Niacin has to go through another pathway in order to, it's part of the salvage pathway to build NAD plus, but there's no channel for NAD plus. So NAD plus is constructed inside the cell. And the study, practically the only study I could find where they tested intracellular NAD plus, or they gave an IV NAD plus, they checked the bloodstream, they checked the urine, and apparently they couldn't find any of the NAD plus. They're like, well, where did it go? Well, perhaps it's doing signal transduction and it's done. I don't know.
So then my patient who had stage 4 cancer, and I gave her the multiple NAD infusions along with vitamin C, NAD infusion, and I also gave her the glutathione and the red light simultaneously. Okay, so that patient is cured for five years now. I shouldn't say cured, but that patient is cancer free for 5 years. So now you don't think that NAD plus play any role in that autophagy, mitophagy in this case?
You gave NAD plus the
Yes.
What else did you give again? Just
I gave her IV vitamin C. I gave her the glutathione.
Yeah.
and you gave one treatment, or was this
5 years ago? I was using glutathione before
and you gave multiple treatments or just one?
Yeah, no, multiple treatments. Multiple treatments. Like over 2 months.
And what was the time lapse, if I may ask, Kalapana? Because Anna Fishbein had a great question, and I do glutathione pushes, I do Meyer pushes, I do CJC 1295, and I noticed that sometimes after I get done with the pushes, I'll go to the bathroom and I can smell the Myers right away. So I don't know how fast this stuff goes through.
No, I don't give. I gave her over 3 hours. So she was there in the office for almost a full day.
So you do the vitamin C, and then 3 hours later you do the
No. I do the IV vitamin C drip. I don't give like people give 1 hour, 2 hour. I give so that the retention is better. Okay. And then I do the another drip for the NAD. And these are all 500 ml bags. And then then I give in a 100 ml bag in glutathione. So the point is that she was in my office at least for 6 hours.
Okay, and this was, again, this was for fibromyalgia, or was this
No,
for?
no, it was cancer, metastatic breast cancer.
Okay, all right, so, and the dose of the vitamin C, are we talking like 25 grams, or are we talking
50 G.
50 grams?
Yeah, 50 grams.
Okay, so, yeah, look, I don't see how NAD plus would help cancer. I mean, just based on my understanding of the mechanisms that I just talked about, I don't see how that would actually, it would be, maybe it helped the other things, but I would think that the vitamin C did.
It is a mitophagy,
work.
autophagy can happen. And that
Yeah,
doesn't kill the cancer.
Yeah, but you know, and I know, when we can't make those assumptions, and we do know that vitamin C at the very high doses triggers
50 mil-
the burst of
50 grams is not
oxidative
very
stress
high.
that has anti-cancer qualities.
No,
And
no.
so how do we know that there wasn't, that the cancer was, you know,
Because
I guess
cancer.
how do we know that the vitamin C was not the one that actually triggered apoptosis of the cancer and put her into remission? That's what I'm trying to say. How do we know that it wasn't vitamin C?
Because of the experience with the different patients, okay? And you, just with vitamin C, you cannot put patient into the 5-year completely cancer-free. And we have a number of patients with lung cancer, breast cancer, prostate cancer. We are treating all of them with vitamin C. We can make them better, but just with vitamin C, we cannot induce any remission in them.
Okay, and then how do we, and I'm just speaking purely scientific here. How do we know that there wasn't a different mechanism that NAD plus had an effect?
Well, I'm reading what I have done and what I
Okay.
see. I'm not claiming, but I want some super smart person than me to tell me that, okay, this combination might have done this, and this. And when you're not combining all three, and all different patients may not respond similarly, if I try another stage breast cancer stage 4 patients, then is she going to respond the same way? I have treated similarly some patients with stage 2, mainly stage 1 and stage 2, so that they don't develop the relapse. And they have all done well, but I not have a stage 4 cancer. I have a ovarian cancer, and ovarian cancer, I'm not using anymore glutathione because of these patients are not emaciated or anything. And I'm not too sure about glutathione being a double-edged sword with it. I want to use it. If there's at all any chance of hurting them, I don't want to use it.
Yeah, I think it's fantastic. There's got to be a mechanism. And I'm not saying that NAD plus, or I don't like NAD plus, or IVNAD plus doesn't work by any means. I'm just suggesting, because we don't have any evidence that it actually increases intracellular NAD plus, I wonder if it's working by another mechanism that is very powerful and working synergistically against cancer. But I think it's a great point, because you said if you did the vitamin C by itself, you would not have gotten that result. So I'm 100% in agreement that I'm wondering what it was.
And the sequence is very important too. You give vitamin C, and then you give NAD, and then you give the glutathione. So I didn't give 2 molecules. I think somebody wrote here vitamin C and NAD, but no, I did vitamin C, NAD, and a glutathione. And that worked in that particular patient.
Yeah, I mean, look, it worked. So I agree. It's I mean, there's something to it. Absolutely. That's my impression. We just need to find out, like you said, or somebody who who knows more than us that might have some insight into the mechanism, because it's not clear with the information that we have. I do know that they're testing 5-amino-1-MQ, the pharmaceuticals are for cancer, but that's because NNMT, that enzyme, has been shown to be
You're right, but
elevated.
where to get the IV,
And-
1Q?
It's not necessary because it's easily absorbed. I mean, I don't, maybe there is, I just haven't heard of it.
And who carries that? And what dose you give?
I've gotten it from South Lake Pharmacy and Shields Pharmacy. They both have it.
Okay, I'll talk to you then. Okay.
Okay, we'll move on to glutathione. So that's interesting. Dr. Patel, you're thinking glutathione, it wouldn't protect cancer cells when you're using oxidative therapies like high dose vitamin C?
Yeah.
Okay, it's good to know. Zinc, do you add this into your COVID protocols, the zinc?
Yes, we do give that zinc, yes.
Of course, zinc is fantastic for that. Beware of stomach upset. IV, if you can get an IV, that's better. A lot of mechanistic reasons for zinc. Melatonin, early in the pandemic, I was reading about some guys using like 50 milligrams in the ICU. They were 200 milligrams, like crazy doses of melatonin in the ICU. I never did that high. I did 300 micrograms is enough for most patients, maybe 3 milligrams. Antioxidant melatonin. I don't know if you guys used much of that, but I always included that in my protocols.
Is it true that you produce most of your melatonin first thing in the morning and that you should do your vitamin D at night?
Vitamin D, and I've heard of that. I can't speak much on that.
Okay.
Vitamin C. In COVID treatment, we don't do the super high doses. I don't know if you guys did that. I was using maybe 3 grams orally 3 times a day. What doses do you guys use for vitamin C, IV or orally?
I use the vitamin C anywhere between 25 to 30 grams IV and orally at least 2 grams 3 to 4 times a day.
Okay, yeah. Great. And vitamin D, I just suggest it doesn't work if you have the sick patient, vitamin D. I mean, sure, but ideally storing vitamin D in your blood over time to therapeutic concentration. I measure blood 70 into the 90s. Vitamin D hydroxy is what I shoot for.
Do you guys use vitamin D for depression? No, vitamin C, sorry, vitamin C infusion for depression. And do you combine that with niacin or not?
I've not used that for. I mean, I'll use it in combination with other therapies to try to holistic approach to treat depression, right? We're doing many therapies, nutrients, vitamin C, not so much a focus in depression. Why vitamin C for depression?
Because Dr. Abraham Hoffer, Canadian
Yes.
psychiatrist, did a lot of studies and showed that high dose vitamin C and that niacin is better than any antidepressant, antipsychotic, anti-anything. So was thinking if anybody had any experience with that, or those of you who do IV vitamin C.
Dr. Tano, wasn't that Dr. Hoffer was using it for depression along with the niacinamide? He was using a very large dose of niacinamide, like
Right.
20 to 30 grams at times.
Yeah, correct.
Yeah, so I think he was using vitamin C and D, but his major emphasis was on niacinamide. And he was using C and D just to make it more complete.
Right, so he was using a whole large dose of vitamin C and the niacin to help this patient, and he got good results. He did a lot of studies of it. He's been having a book on it.
Wow.
Now he has very, very, very good articles on this.
That's excellent. And let's see. If we had Halasa here, I'd query him on oxytocin, but I've not used it for acute COVID.
But oxytocin has many more uses besides COVID. So, like when they have the problem with the circulation, cold hands, cold feet, it helps. It helps also from chronic constipation, for leaky gut, so for irregular menses. So it does help, and you can use it for as a nasal spray. So that is another benefit for that.
Yeah, but the 40 milligrams, I think Dr. Bomer was saying.
Yeah, yesterday, Dr. Beamer was talking also about Dr. Thomas Levy. He's in talks with Dr. Thomas Levy with vitamin C. And I believe, Dr. Joseph, if you correct me if I'm wrong or right, wasn't that with methylene blue? Aren't they trying to combine vitamin C and methylene blue?
As a nasal spray or as a
I think so.
IV?
I think both.
Because I do
No.
vitamin C and
Or was it
methylene blue.
oxytocin?
Oh, with oxytocin.
It was the oxytocin nasal spray.
Yeah, I use the oxytocin nasal spray, and I also use the methylene blue nasal spray.
At the same time. Okay.
Well, one follows the other, and because they have to snort a little bit and make sure it goes inside. First, they have to, blow their nose and make sure there is no secretions, and then they start. And only one spray at a time on each side, and then following that, they can have another spray. Because if they use two sprays on one side at the same time, it may not be used completely.
Wow. Okay. Thank you.
Great.
I think when it comes to COVID, the idea of the intranasal spray with the oxytocin and methylene blue, first of all, it's good I use it on a regular basis. Again, I like that security of having, something that is protecting me against unknown pathogens. Okay, especially through the intranasal route. That's where COVID seems, in other whatever variants or whatever it is, seems to be getting through the nasal passages. Number two, oxytocin's been shown to have antiviral qualities more from the fact that it thins out the secretions or increases secretions naturally, because it's restoring sort of like the parasympathetic innervation in relation to sympathetic, and that increases secretions, including the eye secretions, eye secretions and intranasal secretions, and it makes it more difficult for the virus to attach to the receptors. Number two, there's a direct antiviral effect from methylene blue, but if you think you're getting sick, then you can just do the spray and then follow it up with intranasal red light, because as far as I understand that the virus, methylene blue staining the virus has some antiviral or ability to inactivate the virus, but if you apply the light, it's 10 times stronger. And also at the same time, I like the idea of doing oxytocin, methylene blue nasal spray, because there's articles out there talking about the olfactory bulb. And what I realize is that we have to protect the olfactory bulb, because if that gets too damaged, well, you have to realize, if you look at the anatomy, the olfactory bulb is sort of connected to the limbic system, the amygdala, the hypothalamus, some of these structures indirectly. But one article was saying that if you have enough damage in the olfactory bulb, that can lead to misfolded proteins in the olfactory bulb that leads to like a domino effect, starts triggering all the other proteins down the olfactory nerve tract to start to misfold, and eventually leading to increased misfolded proteins, either through Parkinson's and through dementia. And after the Spanish flu they, in this article, they had talked about the fact that cases of Parkinsonism skyrocketed, went way up. And so the question is, yeah, perhaps doing oxytocin nasal spray and methylene blue, because methylene blue is buffering the redox, it's working along with those oxytocin pathways, and oxytocin is improving metabolism and autophagy and has anti-inflammatory effects and repolarizes the immune system, enhances healing, I believe through activation of AMPK as one of the pathways it leads to mechanistically, and that's serving as a reparative approach. So we got to protect our olfactory bulb. And also think about this. There's an association between loss of smell and Parkinson's. Okay, so something's going on there, but you wouldn't think necessarily, I need to protect my olfactory bulb. So that's where I'm coming from.
That's interesting. Have you ever been able to regenerate loss of sense of smell or taste with oxytocin intranasal?
Theoretically, you should. I've had one person I tried, I was unsuccessful, but I wonder if he needed to do it. He didn't do it twice a day, like I told him, and did it consistently. I think he did one round, and 6 months later, I asked him, I said, how's your smell going? No, it's still not back completely. And, so I think you have to do it a lot. But again, in the literature, they're saying that there was literally in the literature, I don't know if it was theoretical or if it was an actual case, and I don't even think it was COVID related, that intranasal oxytocin could restore smell. And it does it by normalizing the parasympathetic and sympathetic nervous system. And maybe there's some other reparative effects on the the nerves coming out of the piriform plate. I don't know.
I'll try it out. Have
So,
you?
Did
Yeah,
you
go ahead.
try with the methylene blue?
What's that?
Did you try oxytocin spray in any patient with the nasal olfactory problem with methylene blue and oxytocin together?
Yeah, that was the one case, but he only did it for I don't think he did it, first of all, religiously, like he should have. And then he didn't continue on it. He needed to get his refills and do it for, probably you'd have to do it. I suspect you would have to do it for 6 months straight, at least.
Usually it comes back in 7 to 10 days.
You see this?
Well,
Yeah, usually it is in my patients, I always ask, when did it come back? Even when on my patients I see and a telemedicine patient, and they mentioned about that it came back, and average was 7 to 10 days. But when it does not come back, then you have to see that what kind of a damage was there, or is it still the organism is there, or still the neurogenesis is not taking place. Because we are not talking about sympathetic and parasympathetic system, but we are talking about the neurons.
Interesting.
And whether the neurons are why are they dying, and then it may be the methylene blue and the light may have initiated the neurogenesis. Another thing is oxytocin would have made that mucus secreting cell to increase the mucus and provide the good barrier. So, I mean, we have to think about all different ways, then the hormonal ways that it works on the pituitary and hormonal axis, pituitary and neuronal axis. So what was the status of that? When it becomes a long time problem, then that some degree of neuronal damage is there and no regeneration.
Yeah, well, that case, his smell had been gone for 2 years. So that's what I figured was the case. Is maybe it was beyond the point of control beyond the point of return. But again, I still have this sort of thought that what if it's still an autonomic dysregulation? And what I mean by that is that I saw that they were doing stellate ganglion, stellate ganglion
Yeah.
injections, the same ones that they do
Right.
they treat
Yeah, you can do
PTSD with.
you can do
And-
yes, you can do it in the nose through the olfactory system. You inject it in that your either the exosomes or your, I mean, your case,
Oh.
you could have tried.
Oh, okay. So we can sort of do that with the intranasal injection that we know how to do.
Right, exactly.
Injecting the middle turbinate, how
That's right,
we numb it
that's
up and, okay, so there you go. And perhaps that sort of anesthetic serves as sort of a rebooting of the nervous system. I guess that's sort of the idea, because that's, I mean, if a stellate ganglion block does it, I mean, all you're doing is numbing up the nerve and the ganglion, and it's sort of like turning off the Wi-Fi and turning it back on. And then it's sort of all of a sudden the parasympathetic and sympathetic nervous system are back in balance with each other versus sympathetic overdrive that is keeping those parasympathetic functions from turning back on. That's the way that I see it. And perhaps we're sort of mimicking that when we do the intranasal injection. Hello?
Okay,
Yeah.
good stuff. Well, we'll end it here. It's very late, 10:05. Great content, guys.
Okay, thanks, Steve. That was great. It was a little different than what we usually do. Always fun. Any final words?
Is that part 1 of 2?
Yeah, I think that's what Dr. Bomer should do. He should do it interactive when he's giving your show here. You know, try to extract some pearls of wisdom out of Dr. Patel.
Okay,
Dr.
I'll talk
Patel,
to
I would like to contact you. I don't know how to contact you.
Don't know how to contact who?
Dr. Patel.
Oh, okay.
I can. You have a pen and pencil to write it?
Yeah.
Okay, it is 716,
716
yes, 830
830
8532.
8532. All right.
That's my cell, okay?
Okay. All right. Yeah, I will give you a call.
Okay, thank you.
Sure. Thank you.
Boom.
There are a lot of questions in the chat. I don't know if you want to stick around and answer a few of them, or maybe just
We covered them as we went along.
Agreed. Right.
okay, so we're good there. Okay. All right, everybody. It's getting late. We got Dr. Beamer next week. He's going to be doing repurposing of drugs for chronic diseases. So that's next week. And anybody have any announcements of anything coming up? We got the Nevada Osteopathic Medical Association, July 27th to 29th in Vegas. If you've never been in Vegas in July, it's a treat and a half, 114 at midnight. And I'm going to be doing non-hormonal therapies to either increase or decrease hormones. So those of you who do not prescribe hormones but want to manipulate them, that's what my topic's about.
Great.
And it's a nice gig. It's like 30 minutes off the main, street.
Out
So
Summerlin. It's not on the strip. It's at the Suncoast. So
nice.
it's away from the strip. And if anybody wants any information, get in touch with me if you want to go. I think it's online also. So it's streamed. So Nevada Osteopathic Medical Association.
Oh, that's great. Yeah, I'll watch.
Okay. Dr. Siegel, by the way, mentions that she makes 14 gallons of raw kefir weekly for her fur babies. So
Super healthy then.
yeah,
Wow.
remember she's our integrative veterinarian. So okay. All right,
So-
everybody. I'll post this as soon as it's ready. And Brad Stoker says putting the fur in kefir. So Steve, thanks a lot. That was great. Take it easy. And thanks for sending me my coat back. And if you want that dance lesson, let me know. Okay.
Okay.
Time's gonna Run out, so, okay.
All right.
All right,
And
everybody, anybody,
you,
John, you got
everybody.
anything? John, you still here?
Just thank you, everybody. It was very good.
How's the medical school coming along? Or are they taking
Everything's
some along?
beautiful, everything's wonderful. And I'm seeing when we have talks like this and it goes 2 hours, that means maybe we should divide these subjects a little bit. So
Yeah.
it allow us to go intense without over.
Yeah, we're lucky not Dr. Dr. Halasa is not here. He'd be here another 2 hours.
Another 2 hours. So, yeah.
All
But
right.
no, everything's good. Thank you so much.
All right. Thank you, everybody. Thank you. I'll see you next week.
Thank you.